we have to make a decision making in severe acute brain injury revolves around three major questions. Uh, will he awaken or when the patient is awake or when will he will be okay? What does okay means? What is the good outcome of patient to whom with respect to patient or with respect to the family member when patient is awake? So these are the three classical question commonly asked in the critically ill patient in the neuro ICU. Decision making in severe acute brain injury involve two main groups. One is the treating team and other is the family. Treating team will decide the triage, what and whom to be mobilized, what procedure to offer and do to the patient, and what to communicate with the family. From the family side, a surrogate decision maker has a role to decide whether to continue, withhold, or withdraw the ICU care. And financial decision, of course, is a big issue to prognosticate the condition of patient to the family member. So now the introduction. Neuroprognostication is the process through which a clinician formulate an outcome prediction, that is the chance of awakening or long-term function outcome. The goal of prognostication is to provide the surrogate with informative information to decide whether the predicted outcome and the path to achieve that outcome are acceptable to the patient or not. When the prognosis is deemed unacceptable to the patient, surrogate may opt to withdraw life-sustaining treatment or place limitation on treatment which do not reach state order. Given the gravity of the decision predicted on the provided prognosis, clinician must invariably render accurate and timely prognosis after acute brain injury. Early withdrawal of life support, early withdrawal of life-sustaining treatment for perceived poor neurological outcome or inevitable mortality is the most common cause of death after acute brain injury. So the tagline is, unless patient is declared brain dead, we can do this is prognosticate, provide a probability of outcome. Now the challenges faces in during neuroprognostication of patient. There are some factor related to the clinician point of view, related to the patient point of view, and the surrogate decision making point of view. Clinicians have imperfect prognostication tools which they may not use systematically. Surrogate may conflict their own preferences with those of patient or inadequately convey the patient value to the medical team. From patient point of view, patient is unable to communicate their basis to their injury or because of the reduced level of consciousness. So the medical team completely rely on the family decision or the surrogate decision. So no single clinical sign or test that gives a clinician adequate knowledge when neuroprognosticating. The process is further complicated by the fact that the recovery from brain injury is often non-linear, influenced by non-neurological factors, and has some degree of uncertainty. So these are the grading of coma states, like coma, vegetative state, minimally conscious. Sorry. This is the disorder of consciousness, including coma, vegetative state, minimally conscious state, and locked-in syndrome. In coma state, there is no sleep-awake cycle. There is no awareness of the patient, and there is no purposeful behavior. But in vegetative state, there is some sleep-awake cycle present, no awareness, but no purposeful behavior. In minimally conscious state, sleep-wake cycle is present, partial or fluctuating awareness is there, and some amount of inconsistent but reproducible purposeful behavior is still there. In locked-in syndrome, sleep-wake cycle is present, awareness is present, yes, motor behavior is also present, but it is limited to the eye movement, like depending on the in the brain. Confounder. We have to exclude all the confounder which mimic like a comma, in condition before any neurological assessment, which reduce the risk of false prediction due to an address confounder like sedation, opioids, neuromuscular blocking drugs, hypothermia, shock, electrolyte imbalance, hepatic and renal encephalopathy, septic associated encephalopathy, and the toxic induced coma. Timing of prognostication. Timing of prognostication is very much important factor to avoid any aggressive treatment and premature withdrawal of life support. Delivering a prognosis too early, especially in the neurological cases, can lead to inaccurate prediction and potentially prevent a patient recovery. While waiting too long can limit the time for prognostication to make an arrangement and give a right quality of treatment. So in case of post-cardiac arrest, we have to wait at least more than 72 hours after ROAC in those patients who do not receive therapeutic hypothermia, but in those patients who receive therapeutic hypothermia, we have to wait another for a revolving period also. In case of TBI, it depends upon the imaging and the ICP trend of the patient. If ICP trend is increasing, early assessment is required. In case of stroke, it depends on the mass effect and the hemorrhage amount and the level of the hemorrhage. In case of toxic or metabolic coma, we have to wait for the drug clearance. When you in doubt, you have to wait and reassess the patient regularly. Now, clinical examination. Clinical examination is a sequential assessment of neurological status of the patient with brain injury. It helps in predicting the severity of the illness and long-term functional outcome of the patient, which include all the brain stem reflexes which mentioned here, like pupillary reflex, corneal reflex, oculocephalic reflex, oculovestibular reflex, gag and cough reflex, motor response like GCS and four scoring, respiratory pattern, and the myocardial status of the patient. Now there are some scores to assess the common outcomes like Glasgow Outcome Scale, Glasgow Outcome Scale extended form, cerebral performance category, condition specific scoring system. So this is the scoring interpretation like Glasgow outcome scale and Glasgow outcome extended form. If the score is more than 4, then patient shows some amount of independent function, so he or she can do their functional daily activities. If the score is less than 4, patient may need full assistance or partial assistance in their activity of daily living. Now came to the neuroprognostication after traumatic brain injury. So as
Dr.
per the
Neeraj,
guideline, are you
don't
ma'am?
you have a clinical scenario?
No ma'am.
See, this presentation is supposed to be clinical based, no? You're supposed to present a clinical case that you have encountered in the ICU, and based on that, this topic is discussed. It's not a theory based PowerPoint presentation.
Okay ma'am.
You haven't attended the previous classes.
Yeah ma'am. Sorry ma'am, I was not aware कि so
So whatever you have made preparation now, you just present, but I think next week you'll have to do again with the clinical scenario. Only then what you're talking will be actually applicable and you will understand. Okay, so you
okay
have
ma'am.
to redo this topic next week again, but whatever you've prepared, go ahead and present it.
Okay ma'am. So ma'am, came to the neuroprognostication after traumatic brain injury. As per the clinical guidelines in the Neurocritical Care Society, here are some clinical variables which predict the mortality outcome or the functional outcome at 6 months and beyond, like including age, bilateral pupillary reaction, unilateral pupillary reaction, GCS scoring, hypertension in the field or emergency department, hypoxia, intracranial hypertension, major extracranial injury, acute kidney injury, and positive alcohol test or alcohol intoxication at the time of admission, hypernatremia during ICU, traumatic cerebral infarction. So, ma'am, most of the guidelines show the at the time of discharge and functional outcome at the at 6 months and beyond, but none of the guidelines show the quality of life and the cognitive status of patient after the traumatic brain injury. And
So, Dr.
eventually,
Neeraj,
none of the single. Okay. Yes, ma'am.
I have two questions. One is
Go, ma'am.
GCS is one of the most important uh, scoring system for TBI.
Okay,
So,
ma'am.
how does GCS fare in predicting the outcome immediate at discharge versus long-term follow-up outcome at 3 months or 6 months, whatever? How does it fare?
Can you repeat, ma'am, question, please?
Glasgow Coma Scale score, the GCS score.
Yes, ma'am.
How relevant is it in predicting the outcome of a TBI patient at discharge versus from admission to discharge versus long-term follow-up at 3 months, 6 months?
Ma'am, early good GCS is better, ma'am. If we do early GCS scoring, that is good for the clinical outcome for patient.
Does anyone else want to answer this question? What is the problem with GPS?
Hmm. Ma'am, I think early GCS monitoring in traumatic brain injury patient is quite good for recovery and good functional outcome at 3 months or 6 months.
No, that is not the question. So basically, only the motor scope. I'm sorry, Dr. Rajesh, your mic is on. Can you switch it off? Dr. Rajesh? Okay, so basically, only the motor score stands any importance in predicting the outcome.
Okay,
I
ma'am.
score could be falsely low if you have a direct ocular injury.
Okay, ma'am.
And any left temporal contusion, the verbal score may be low, but that may not correlate with the functional outcome.
Okay, ma'am.
Statistically, if you look, there was M3, M2, and M3 when they were compared. M2 score had a higher functional outcome and survivability compared to M3 score. That doesn't fit. That is how Glasgow Coma Scale pupils, GCSP, came into being. Because pupillary signs at admission also have a very vital role to play to predict the outcome in the long term. That's how GCSP came.
Okay, ma'am.
But now, of late, both for cranial and spinal injuries in TBI, the period of 3 months and 6 months does not correlate with the final outcome. People are looking at a long term, up to 2 years, neurological recovery is possible, provided you provide rehab. So, the 6 month and 3 month outcome and the various literature suggesting this is good, that is good, is no longer held true. We are looking at a point beyond 6 months, even up to 2 years. Okay. And if you take India per se, there is a publication from our center in JNS. We
Okay,
have almost similar outcome parameters, functional outcome parameters at discharge compared to the Western world.
okay,
But
ma'am.
once discharged, 3 month and 6 month outcome is very bad. Basically, we don't have rehab facilities.
Okay, ma'am.
What is impact score? What is crash TBI?
Okay, ma'am. Ma'am, impact score. Ma'am, impact has a three model: impact core model, impact extended model, impact lab model. Ma'am, impact core model predicts 6 month outcome mortality and unfavorable outcome without the CT scan. It includes age, GCS motor scoring, and pupillary reactivity.
Why does it not hold true for us? We don't use that, no? Do you use impact
Uh,
calculator and speak to the family? You don't. Why? Because impact looks into the financial status of the country.
okay,
Low
ma'am.
income country, high income country, it doesn't hold good anymore for India. Someone sitting in Apollo and treating the patient is as good as the Western world. He cannot use the impact low income country scale to predict the outcome. So
Okay,
impact does not correlate much with the Indian population anymore. Even the crash one doesn't fit properly because the CT scan does not correlate with the outcome. You may have a diffuse axonal injury, the young patient who will go into PSH, paroxysmal sympathetic hyperactivity. After three weeks, he will be all right. So these predictive models, you have to be very, very careful when you're speaking to the family based outcomes based on these values.
This model.
Anybody has anything to clarify or shall we move ahead? Fellows, please speak up. If nothing is there, carry on.
Okay, ma'am. So, ma'am, this is the study shown in the JAMA. Ma'am, this is the study. Now, this is a study called Track TBI, published in JAMA Neurology in 6 July 2021. This study predict the functional outcome over the first year after moderate to severe TBI. It is a prospective and longitudinal study which conclude the patient with moderate to severe TBI frequently demonstrated major functional gain, including recovery of independence between the 2 weeks and 12-month post-injury. Severe impairment in the short term did not portend poor outcome in substantial minority of the patient with moderate to severe TBI. When discussing prognosis during the first 2 weeks after injury, clinicians should be particularly cautious about making early and definitive prognostic statement suggesting poor outcome and withdrawal of life-sustaining treatment patient with moderate to severe TBI.
Exactly what we discussed.
Yes, ma'am. This is the graph showing at the 12 month of outcome. Glasgow outcome scale extended from 52% patients show a good recovery. Now, ma'am, came to the neuropronunciation after intracerebral hemorrhage. As per the guidelines, uh, in terms of neuropronunciation following intracerebral hemorrhage, they passes some good practice statement in accordance with the recommendation of GRADE network. These statements required for good clinical practice for neuropronunciation included most of the neuropronunciation of patient with ICS should be generally defer for at least the first 48 to 72 hours of ICU admission. Factors such as pre-existing cognitive impairment, poor baseline level of functioning, pre-existing illness associated with lifetime expectancy, and multi-organ failure are considered at the time of prognostication. Long-term cognitive and psychological impairment are common among patients with ICH who do not necessarily meet criteria for poor functional outcome. Care should be taken during counseling of individual patient family to understand what outcome should be the most valued by the patient. These are the some clinical factors of poor outcome at 3 months or later, which include age, clinical examination at the time of admission, ICH volume at time of admission, infratentorial location, interventricular hemorrhage, anticoagulation patient was taking, some clinical grading scale which show like original ICS scoring and max ICS scoring. But ma'am, none of the single predictor considered to be a reliable predictor in the outcome of the in the functional outcome of patient. This is a study. This is a study published in Neurology 2061. This study compared the performance of formal prognostic instrument versus subjective clinical judgment with regard to predicting functional patient with spontaneous intracerebral hemorrhage. Conclude early subjective clinical judgment of physician correlate more closely with 3 month outcome after ICI than prognostic scale. This is a graph clearly showing the attending doctor and the nurses have almost equal level of prediction with 3 month outcome score is better than ICI scoring and fungus scoring. Now came to the neuropronunciation after cardiac arrest. Ma'am, as per the guidelines suggested in neurocritical care team with good practice statement, we recommended deferral of assessment of neurological prognosis or comatose survival patient of cardiac arrest for at least 72 of hours following RLC in patient with not treated with therapeutic hypothermia and at least 72 hours following revolving period in patient treated with hypothermia. We also recommended that the neurological prognosis of comatose survivor of cardiac arrest be performed in the absence of any confounder like sedation and other neuromuscular drug. We also recommended that factor the overall prognosis is based on poor baseline level of functioning, pre-existing illness associated with limited life expectancy, and multi-organ failure can be considered prior to the assessment of neurological prognosis of comatose patient. We also recommend that the assessment of the neurological prognosis of comatose survivor of cardiac arrest must be multimodal with consideration of the complete clinical scenario, never based on a single variable. We also recommended that the absence of reliable predictor of outcome, surrogate of cardiac arrest survival, who remain comatose at the time of neuroprognostication, be counseled that the likelihood, extent, and the time course of neurological recovery is uncertain. These guidelines are easily available on neurocritical care team guideline website. There are some predictor of functional outcome at 3 months or later, ma'am, which include age, initial cardiac rhythm, time of return of spontaneous circulation, neurological examination, brain imaging like CT and MRI, electrode diagnosis, some biomarkers in CSF and blood, and then some prediction model. So, ma'am, the usual approach of neuroprognostication, this graph showing the usual approach of neuroprognostication like 0 to 72 hours, we have to give supportive care and serial neurological evaluation, avoid any confounder, obtain prognostic information if not withdrawing to pain with the help of video EEG, CT scan, serial neurological examination, MRI between 40 to 75 data is appeared into contradiction. If all the neurological criteria of brain death is met, patient declares a brain death. If no, then 72 hours motor examination should be done. If there is a localization of withdrawal to painful stimulus, yes, indicate a favorable prognosis. If no, then we have to check out. We have to assess the brainstem reflexes like pupillary response, corneal reflexes, bilateral absent, and 20 waves in SSEP in more than 24 hours, highly malignant EEG or bus suppression background EEG for more than 24 hours, and various biomarkers in blood and serum, status myoclonus present or not, and diffuse extensive adrenal injury present or not in CT or MRI. If these all are present, indicate definitely poor outcome, poor functional outcome, and poor prognosis. If not, if prognosis is unclear, consider ongoing support with serial examination, evaluate and treat the confounding factor, perform additional neurodiagnostic testing if not already done. Now, neuroprognostication after aneurysmal SH, there is no such guidelines available for for any aneurysmal SH guideline, but there are some clinical predictor which predict the functional outcome of patient in case of aneurysmal SH like age, higher Hunt head grade, higher WFNS score, aneurysmal size and location, chances of rebleeding, presence of ICH and IVH, and delayed cerebral ischemia. These are some biomarkers helpful in the neuroprognostication of patient, like in case of traumatic brain injury, tau protein, GFAP protein, UCH, L1 protein, and S1100 beta chains. In post-cardiac arrest patient, S100 beta chain, NSC, neurofilament light chain is useful. And these biomarkers we can do in CSF also as well as in blood also. Now, ma'am, role of imaging in neuroprognostication. Ma'am, role of imaging neuroprognostication include two main things like CT brain and the MRI. CT brain, commonly etiology of disorder of consciousness such as ICH, ischemic stroke, SAS, cerebral edema, herniation, and hydrocephalus are detectable on CT. CT may be useful to predict poor outcome in some patients with acute brain injury. Loss of gray and white matter interface signifying cytotoxic edema post-cardiac arrest has been studied as a marker of severe hypoxic ischemic brain injury. A low ratio of gray and white matter on CT is an early predictor of poor neurological outcome after cardiac arrest. Given significant limitation in detecting and adequately prognosticating disorder of consciousness, has CT rarely used in isolation as a prognostication tool. Now, structural MRI. Structural MRI is a key multimodal tool in prognostication because it provides the anatomical, diffusion, and tissue level information that correlate likelihood of recovery after disorder of consciousness. It is not used alone for prognostication, always combined with EEG, clinical examination, evoke potential, and timing. MRI revealed the extent of brain injury, either it is focal or diffuse, location of the injury in different parts of the brain, types of the injury, it may be either ischemic, hemorrhagic, or traumatic, and tissue viability via diffusion and T2 flare changes. Now, MRI sequences, there are different sequences of MRI we are commonly used in neuropronunciation like diffusion weighted imaging plus ADP maps. Most important for early anoxic injury. It shows cytotoxic edema from hypoxic ischemic injury, diffuse cortical and deep gray matter diffusion restriction. If it is there, indicate poor prognosis. Quantitative ADC threshold are being studied. Strong predictor when finding are bilateral and extensive. In T2 flare, T2 flare images highlights the cortical laminar necrosis, basal ganglia injury, thalamic involvement, hyperintensity. If there is a hyperintensity in the cortex plus deep nuclei, they strongly correlate with a severe hypoxia injury. Help to distinguish reversible edema from the necrosis. SWI imaging for the traumatic brain injury. Traumatic brain injury, it detect microhemorrhages consistent with diffuse external injury. Grade and distribution of microbead correlate with long-term outcome. Brain stem diffuse external injury indicate very poor prognosis. Corpus callosum brain diffuse external injury, it also severely disability likely. In structure in T1 images, pre and post contract show cortical necrosis and subacute changes. Less useful for early prognostication but helpful for the long-term prognostication. So MRI basically offer what? MRI offer higher sensitivity versus CT, early detection of irreversible damage, better assessment of white matter in integrity and deep brain structure. So what is the strength and limitation of MRI in the prognostication? Strength, what is the strength? High sensitivity for anoxic injury, identify latently severe injury missed on CT, help distinguish vegetative state versus minimally coma state, conscious state when structural correlate exists, guide family discussion with visual evidence, strongest predictor when MRI abnormalities are extensive, bilateral and involving deep gray matter. What is the limitation of MRI? The timing matter. Too early, when we do too early MRI, it is a false negative test. In case of sedation, ventilation, and ICU therapy, delayed transport, not interpreted in isolation, cannot directly measure awareness or network function. Condition specific prognostication. After cardiac arrest, post hypoxic ischemic injury, MRI is most useful 2 to 7 days after ROC once sedation confirmed or resolved. Poor prognosis indicators like diffusion cortical D1 restriction images, basal ganglia and cerebral diffusion restriction involvement, cortex plus deep nuclei intensity seen on MRI, loss of gray and white matter differentiation. So basically, MRI is a part of the multimodal prognostication algorithm used in the neuropsychiatric care guidelines. Now, in case of traumatic brain injury, poor prognostic markers in MRI like diffuse axonal injury involving brainstem or corpus callosum, multiple microhemorrhages on SW1 images, diffuse T2 hyperintensity in the white matter, brainstem impaction injury. Focal injury can still have good recovery if managed earlier. Some condition specific prognostication like stroke related disorder of consciousness, a specific pattern predict prolonged disorder of consciousness like bilateral thalamic infarction, large pontine infarct, massive hemispheric stroke with herniation. So basically MRI helps to distinguish reversible injury from irreversible brainstem injury. In case of metabolic or toxicoma, MRI can identify characteristic reversal pattern like hyperammonemia, there is a cortical swelling. In case of hypocalcemia, there is a deep gray plus cortical diffusion restriction is there. In case of carbon monoxide poisoning, global palatal injury is there. So prognosis depend on the extent rather than the diagnosis alone. Now, what is the use of functional MRI in the prognostication? Functional MRI assess brain activity, not just structure. It measures the blood oxygen level dependent the bold signal to detect the neural network function. Bold signal based functional MRI approaches rely on detecting changes in the bold signal associated with neural activity. Neuronal depolarization triggers a hemodynamic response, increasing the amount of oxygenated blood related to the deoxygenated blood. This lead to a net increase in the local magnetic resonance, which lead to a bold contrast in region of increased neural activity. Detecting covert consciousness, some patients diagnosed as a vegetative state and unresponsive wakefulness state demonstrate willful brain activation despite no motor output. How to test is patient are instructed to imaging. He or she will be imaging playing tennis will activate supplemental motor area. Imagine walking through their home will activate their parahippocampal region. If correct brain area activate, patient has covert consciousness. So what is the prognostic significance? Presence of command following on functional MRI associated with higher chances of emergence from minimally coma state, better long-term functional outcome, lower chances of permanent vegetative state. So it indicates preserved cognitive network despite absent behavior. So this is the most powerful predictor of potential recovery. Now, resting state function MRI. Resting state function MRI evaluate intrinsic brain network without asking a patient to perform tasks. Most important network like DMN, default mode network, frontoparietal network, and the silence network. What is the prognostic insight? Intact or partially preserved DMN network indicate better recovery. Severely disrupted DMN network indicate poor prognosis. And the connectivity between the posterior cingulate cortex and the medial prefrontal cortex correlates strongly with the outcome. This is especially useful in anoxic brain injury, TBI, vegetative state, and minimally coma state differentiation. Minimally conscious state. Distinguish vegetative state versus minimally conscious state. Structural MRI may look similar in both, but function can show differences. In minimally conscious state patient, greater network integration and reserve auditory and visual activation. In vegetative patient, minimal absent cortical activation. Function MRI reduces misdiagnosis rates, which are otherwise 30 to 40% in disorder of consciousness. In case of sensory or language processing function MRI, auditory stimulation can show the activation of primary auditory cortex, that is, indicate the reflexia, activation of higher order language area like Wernicke's area, Broca's area, consistent with the preserved awareness. So, higher order activation predict better and long-term cognitive recovery, lower chances of permanent vegetative state. So, what is the limitation of functional MRI in prognostication? Not yet standard of care, usually mainly in research center, require high specialized analysis. Practical barrier include motion artifact, hemodynamic instability, ventilator, ICU hardware compatibility, deep sedation, transport risk in case of critically ill patient who are in high support, high INOT of support. Interpretation challenges like lack of universal threshold, false negative value, patient may have consciousness but cannot participate. Both signal abnormality do not always equal irreversible injuries. Now came to new modality, near infrared spectroscopy. What is measured? It measures regional cerebral oxygen saturation, a reflection of balance between cerebral oxygen supply and the demand. It's a continuous bedside real-time trend. It primarily monitors frontal cortical oxygenation. Why NARS matter in coma prognostication? While NARS does not directly assess awareness, it helps to prognosticate by identifying the cerebral hypoxia, maladaptive cerebral autoregulation, persistent low frontal oxygenation despite systemic stability, cerebral desaturation during ICP crisis, hypertension, or these seizures. Pattern correlate with secondary brain injury, which influence long-term prognosis. After cardiac arrest, NARS reading in early post-RSC period have prognostic value. Good prognosis associated with higher baseline regional saturation oxygen in more than 50 to 60%, increasing train in the first hours after RSC, stable bilateral symmetrical value. Poor prognosis associated with very low level of regional oxygen saturation after RSC is less than 30 to 40%, persistent low value despite adequate systemic oxygenation, asymmetric regional saturation oxygen indicate focal injury or poor perfusion. Lack of improvement in the regional saturation oxygen over time, the train is more productive than absolute number. In case of traumatic brain injury, NARS can reflect cerebral hypoxia during ICP crisis, compromised autoregulation, poor perfusion in diffuse external injury, It also indicate poor prognostic indicator like if regional saturation of percentage less than 50%. Recurrent desaturation is still there. Events happening in the ICU. Poor coupling between ICP, MAP, and regional oxygen saturation. Loss of auto-regulatory pattern. These correlate with diffuse external injury severity and worse neurological outcome. In case of stroke or global hypoperfusion state, NARS help to detect cerebral hypoxia in large hemisphere stroke, delayed cerebral ischemia in case of subarachnoid hemorrhage, border zone ischemia due to low perfusion, while not diagnostic. Persistent low regional saturation oxygen correlate with poorer recovery. Now came to the positron emission tomography. PET scan basically measure the glucose metabolism. Most important is part brain energy use measured by a standardized uptake value, low SUV indicate low activity and poor recovery potential. Secondly, neurotransmitter PET, this is a less common feature. Dopamine, GABA, and acetylcholine receptor research only. It is a research part only. Can characterize network dysfunction in DUC. It helps in determining whether the brain has residual function activity or not, whether the cortical network are metabolically active enough to support consciousness or not, or whether a patient in vegetative state or unresponsive wakefulness state has covert consciousness pattern. In vegetative state, if global cerebral metabolism is 30 to 40% of normal, 30 to 40% is normal, but marked reduction in case of frontoparietal association cortex, posterior cingulate cortex, and precuneus. Prognosis very low chances of significant recovery if metabolism is less than 40% and symmetrical. In case of minimal conscious state, global metabolism is somewhat higher than global cerebral, it's somewhat higher than the vegetative state, like 50 to 60% normal. In this case, preserve some island of metabolism, especially in the precuneus, posterior parietal cortex, and prefrontal cortex. Prognosis much higher chances of recovery as compared to the vegetative state. So basically, PET is one of the best tool to differentiate vegetative state versus minimal conscious state. Now, emergent state from metabolic level approaching 70 to 80% normal. Restoration of connectivity in default mode network, frontoparietal network. Prognosis good potential for functional improvement. Covert consciousness and cognitive motor dissociation. PET can detect normal or near normal metabolic pattern in patients who appear unresponsive at bedside, indicating hidden cognitive capacity. This is highly predictive of later recovery of command following better long-term cognitive function. Now came to neurophysiology. Physiology EEG analysis in case of brain injury to prognosticate the coma status. EEG is based on recording post-synaptic potential generated from cortical neurons using electrodes. Why EEG is critical in prognostication? Because EEG helps to determine the degree of cortical dysfunction, presence substance activity, malignant pattern, as maybe suppressed pattern, loss of pressure pattern is there in the EEG, presence of status epilepticus, early indicator of cortical viability. It is continuous and site and unaffected by MRI compatibility issue. Timing of EEG. Two main time points are very much important. Early EEG and definitive EEG. EEG should be done within 24 hours. It is useful for identifying the seizures or status epilepticus, detecting early highly malignant pattern or highly malignant pattern, though selection may confound. Risk stratification but not definitive prognostication. Definitive prognostic EEG should be done more than 72 hours post ROSC, performed after normothermia achieved and after sedation washed out. Patterns seen at this time point carry highest liability of for prognostication. Highly malignant EEG pattern strongly predict the poor outcome when present more than 72 hours of post ROSC without the sedation. Suppressed background in the EEG pattern show EEG amplitude less than 10 microvolt, no background activity, indicate severe cortical injury, indicate poor prognosis. Burst suppression pattern in the EEG, repeated pattern of burst separated by a long period of suppression, especially malignant when identical burst and there is no reactivity. Status epilepticus on a suppressed background, refractory status epilepticus, along with the suppressed background, indicate extremely poor prognosis. Study epileptica on a continuous background has a better outcome potential. Now, EEG malignant pattern, unreactive continuous background, seizures, generalized slowing, generalized periodic discharge, electrographic seizure in first 20 to 48 hours. These patterns require combination with other modality to conclude poor prognosis. Benign or favorable EEG pattern include continuous background activity. Continuous background activity restore continuity indicate improved cerebral function associated with good neurological outcome. EEG reactivity respond to the noise, pain, light, and suctioning. We see one of the strongest good prognostic marker. Absence of reactivity considered malignant. Normal sleep architecture, presence of sleep spindle or K complexes indicate high likelihood of recovery. Reactivity tested by applying stimulus and watching for EEG changes. The presence of EEG reactivity indicates a strong predictor of good function outcome. It reflects preserved thalamocortical network. Absence of reactivity indicates a strong predictor of poor outcome. Need to be confirmed once sedation is fully worn off. Unlike routine EEG, continuous EEG allows train monitoring, background continuity, reactivity changes in the background, detection of any fluctuation state, capturing intermittent seizure that routine EEG might miss, assessing evolution of malignant to benign or vice versa pattern, distinguishes transient sedation effect from two cortical failure, guideline treatment decision for epilepticus. So, thus, continuous EEG gives a temporal, not just a snapshot view of cortical health, is very important for critical for prognosis. Now, background continuity, most important prognostic feature. Continuous background emerging within first 12 to 24 hours indicate good outcome. Persistent background for more than 24 to 48 hours indicate poor prognosis. Transition from discontinued to continue on continuous EEG indicate very favorable sign. Routine EEG cannot capture these transition. Continuous EEG can. So EEG reactivity may appear intermittently when continuous EEG increase detection accuracy. Reactivity appearing at any time indicate highly predictive of good recovery. Persistent absence of reactivity of more than 72 hours without sedation indicate poor prognosis. Continuous monitoring ensure reactivity testing is not missed. In case of seizures and stutter epilepticus, non-convulsive
Dr.
seizures
Neeraj,
occur in 10 to
how many more slides
12.
do you have?
I think 10, 12 slides.
I think this is being just theory. Nobody is capturing anything. Aparna ma'am, if you agree with me, can we get back next week with a clinical scenario and make a flow chart of what
Sure,
we have, what tests we have, clinical and bedside, that we can use right away, and those that which are not available, and what is to be looked for. Instead of 5 slides on continuous EEG, you show us a background pattern that will stick to everybody. This just reading out what is written is not helping us. So I think what we
sure,
should
ma'am.
do is come back next week with a clinical scenario and then you explain all this. Okay, Dr. Neeraj?
Sure.
Okay, ma'am. Done,
All
ma'am.
right. I think as of now, we'll take a break and we'll gather next week, Thursday, 7 p.m., and we'll see how we can understand this topic better. Okay? All right.
Okay,
Then.
ma'am.
See you.
Thank you, ma'am. Thank you so much.